I encourage you to have a look. But it's what Marco brings to the issue of oral health and equality that is so highly impressive. Marco is totally dedicated to the identification and understanding of health inequalities in general, and oral health inequalities in particular. And that is a significant feature of his CV and his 250 plus peer-reviewed publications. He's been part of the GOHIRN network from the outset, which is a decade ago now, and has won the Distinguished Scientist Award for Global Oral Health a few years ago. So it gives me great satisfaction to see him here in the role of president. I don't think there's anyone in the world better qualified to undertake this role. There is no doubt that his mentorship under the Aubrey Shyam School has helped to forge his great interest in inequalities. And one of the things that very first things that Marco did as president was to forge a more formal relationship with the ICOHIRP group through his professional and his personal relationship with a colleague at UCL, Richard Watt. So this relationship between these two organizations is a very natural liaison, as it brings together two of the world's leading public health groups with a common interest in addressing health inequalities. And the outcomes of our deliberations can be brought to, and I'm sure influence, the ongoing dialogue with the Lancet Commission, for example, and with the World Health Organization, who are currently producing their report and strategy and action plan. So to today's presentation. So this is coming at a very interesting and exciting time to be discussing in a global webinar, as birth cohorts studies offer unique opportunities to help us understand the role of biological, psychosocial, and behavioral processes that influence health across the life course. So it's my pleasure to hand over to Marco to present his webinar entitled Life Course Socioeconomic Changes, Impacts on Oral Health, Findings from Birth Cohort Studies. Over to you, Marco.
Thank you, Peter. Thank you very much for your kind introduction. And publicly, I would like to acknowledge your fantastic work done as a president of GOHIRN in the last term. Thank you so much. Thank you, Carol, for preparing the invitations and to actively be involved in this webinar. It's my pleasure to be the inaugural webinar of this joint initiative that I think that I look forward to have more opportunities with you guys. So let me, for some reasons, Carol, I think that I have to share my screen again.
Yes, Marco, please, if you don't mind.
Yeah.
Yeah, that's fine.
Can you see?
You. Yes.
Yeah.
Thank you.
Okay. Well, as Peter said, the idea is to present some findings from population-based cohort studies addressing the topic of life course socioeconomic changes. So the journey that I think that's about 30 minutes, and after that we can discuss more, is to give a brief, very brief overview about the current theories on life course epidemiology, and particularly about economic changes over the life course, a relatively unexplored area in health, I have to say, and particularly in dental research. And after that, I'm going to show some empirical studies from some cohort studies that I've been involved in since 1998. So you will see a develop of the methods, the skills and the tools applied to this field as well. And finally, is a matter of brief, I think that's an invitation to embark in this topic from colleagues from all over the world, those involved, particularly those involved in cohort studies, to look at the socioeconomic inequalities over the life course and influence on oral health. What's the importance of addressing this issue? I think that we have basically three main issues here. The first one is you are going to talk about socioeconomic inequalities in health again. It's the same, more of the same. I think that the health inequalities persist, and we need to continue to denounce this as an unfair and unjust inequalities that happen, that's not motivated by any biological or genetic aspects, but purely originated by how the societies are structured. The second one is how to inform policymakers the most appropriate time to intervene, if there any more appropriate time to intervene. And finally, to access not only the socioeconomic inequalities over time, but also the impact of policies on the burden of oral disease, but also in reducing socioeconomic inequalities. So the classic definition of life course epidemiology is the study of long-term effects of later health or disease, physical or social, I emphasize social exposure during different periods of the life, since gestation, throughout adulthood, and then later adult life. And the aim is to elucidate the complicated mechanism that link biological, behavior, and psychosocial factors that operate across the individual's life course, but also across generations, and influence the development of disease. So the assumption here is that social trajectories or social patterns shapes individuals' life and consequently individuals' health. So there are many different theories, or many different authors emphasize different theories or proposing different theories. But basically, I'd like this very simple and schematic definition, grouping the main theories into four main groups. The first one came from the seminal work by Barker from the UK. It's very biological in initial, but at this time I will emphasize the social acts. But the first theory is programming or critical period, advocates that exposure during a key development period of a particular individual's life, in particular early life, leads to a condition later in life. The second theory is that there is a critical period. They acknowledge the existence of a critical period, but is modified later on by some other exposures. The third theory is that there is accumulation of risk. So detrimental and beneficial exposures are accumulated through the life, affect health and disease later on. And finally, the chain of risk, one expose leaders in a fair linear way to another to influence health later on. So they are not mutually exclusive, they can be combined. And this is, as you can see, this is in this book by the famous economist, Amartya Sen. This is influence, move beyond the field of health. For example, in this book, The Development as a Freedom, Amartya Sen proposed, now it's very well known, the first 1,000 days of children's life as a critical, not only for education, but also for income, employability, and for proceed in life, including health. So these theories influence different sectors of research and policies beyond the health field. So we adapted, Stefan, Anja, and I, in the first monography of ICOHIRP and published some years ago. We adapted a well-known schematic proposal of how life course events interact in different periods of life, from the prenatal, infants, childhood, and later on, and interacting different skills, knowledge, work experience, and so on. So the proportion of the influence of every factor here change over the life course. So for those who are interested in this field, there are many different books focus on different aspects, different disease-oriented or sometimes expose-oriented approach, and also some key publications like this glossary of life course epidemiology published many years ago. But in addition to the books, we have also, I don't know if you were aware of this, many journals, many periodicals we publish in sociology and even in the health field. The right hand side journal is originated by from the Barker's group, the more biological, while the social stratification mobility focus on more sociological aspects and economic aspects of the social mobility of the life course. So this is it's a very wide field, and my task today is to focus on one particular aspect, speaking using epidemiological language, one exposure, which is socioeconomic inequalities or socioeconomic position, social stratification. The idea when I started this was very to apply a more critical approach, identify very few actually studies using, for example, the Marxism class analysis, more comprehensive, including the relationship between power, class, race, and gender. So this is the ideal world. But at the end of the day, for epidemiological empirical studies, is very difficult, and it's a big challenge to operationalize these very complex factors or structures of the society. At the end of the day, we rely in very classic and sometimes reductionist measures such as income, wealth, education, and even occupation. But this is what we have been done so far. So one thing that I'm going to focus on one particular, I'm narrowing down the approach. I'm going to focus on income. And then it's important to make a differentiation between wealth and income. Sometimes they are come together, but sometimes they are distinct entities. As you can see, there's a beautiful infographic made by the Australian Bureau of Statistics, looking at the Australian income and wealth distribution across generation. Lots of information in this infographic, but if you can see in the generation Y, the aged 25 to 34, they are about 15% of the population, but they have 7% of the national wealth. So a relatively small proportion of wealth. But if you look at the average annual household income of this generation, actually is higher than the generation called the older boners or even the builders, the oldest generation. So this I brought this graphic here, this infographic here, just to make a distinction between wealth and income. Wealth is much more complicated to collect, and income. It's not easy to collect as well, but there is a different change over the life course. And wealth, sometimes the most wealthy groups are not those who earn more higher income. This is a distinction that needs to be made. So now I'm going to show some very basic studies, but it's very important to illustrate how the changes income over the life cycle happens. This is based on the British Household Panel study. Of course, this is applicable to is valid for the UK and the Britain context. This is a question mark if this can be applicable to other contexts. But anyway, I think that's quite useful to see that you can understand income and poverty dynamics benefits from taking a life course perspective. So a person's age and family circumstance shape life cycle, which in turn affects the likelihood of experience key life events, which in turn also affects the probability of experiencing rising, failing, or other income trajectories. Based on this panel surveys, the authors propose 6 different trajectories that you can see here with these proportions relatively similar, a flat trajectory, a flat with blips, rising, failing, fluctuating, and some others that's difficult to characterize. But if you can see here, there are at least 6 basic income trajectories over the life of course that can understand what happened in terms of key vital events over the life. Well, but we are interested in moving from association to causation. The question here is if the social, or in this case, socioeconomic condition, or more specifically income, may affect the distribution of health states, in our case, oral health status. If so, if there is a direct effect of this effect is mediated by behavior or access to care or some other characteristics. In this diagram, I'm using a schematic DAG, direct acyclic graph. X is the exposure, in this case is socioeconomic position, and Y is the outcomes, in our case, maybe caries or periodontal disease or tooth loss. So one task of epidemiology is to inform interventions that we can change X to impact on Y. So this is the direct effect. But on the other hand, we can have the X through M influence Y. And then we need to inform preventions, how we change. Sometimes, most of the times I can see that pragmatically speaking, we are trying to intervene on mediators rather than the causal distal factor. But sometimes we need to know if there is a direct effect that we can identify, and then a more structural change is necessary. So we need to consider in life course epidemiology also, L here is represented by time varying confounders that you need to be taken into account. So this is a schematic DAG that I'm talking about that because our research team over the years has tried to move from association to causation, and then to propose interventions to change what I call X or the exposure, or M, the mediators, to improve population outcomes. Therefore, let's start talking about causation or causal language. In this slide here, I'm trying to make a distinction between association and causation. Association, as everyone knows, is defined by the different risk in two disjoint subsets of the population determined by the individual's actual exposure value, capital A equal 1 or equal 0, whereas causation is defined by a different risk in the same population under two different exposure values, lowercase a equal 1 or lowercase a equals 0. The definition of causation implies a contrast between the whole white diamond, all individuals treated, and the gray untreated areas of the original diamond. Association, therefore, is defined by a different risk of the outcome in two disjoint subsets of the population determined by the subject's actual exposure value. Causation is defined by the different risk of the outcome in the same subset. For example, the outcome population under two potential exposure values. So, and now, under this very classic scheme of the cohort studies, consider a gold standard study design for assessing causality in observational studies, given that what we are talking about is not possible to be treated in a randomized clinical trial, for example, but the recent advances in epidemiology and statistics make possible to provide causal inference and to mimic randomized clinical trial as I tried to define it in the last slide. So let's move on. So now I'm going to present, after this brief overview, I'd like to present some empirical studies looking at changes in particularly in income over the life course and the importance of different periods of life on different oral health outcomes, particularly dental caries, periodontal disease, and tooth loss. My motivation came from academic and non-academic reasons. As a Brazilian, you can see here, Brazil is one of the most unequal countries in the world. Unfortunately, Carol, Colombia is close to Brazil as well. So it's impossible to live in a country like Brazil, and the socioeconomic inequality don't touch you. So this is the more political, ideological, moral motivation. On the other hand, I've been fortunate enough to be in touch with one of the most brilliant scientists in this field, in epidemiology, Professor Cesar Victor. And I started with some colleagues the oral health assessments of the existing cohort studies in that city, Pelotas. And that's what I'm going to show you now. So this group in south of Brazil, in Pelotas, are very well known for producing high quality epidemiological studies, but more recently to host a WHO collaborative center in health equity, the International Center for Equity in Health in Pelotas. And unfortunately, there is no publication in English, but in Spanish and Portuguese, a very famous and highly cited book talk about the epidemiology of inequality, focus on the 4 existing ongoing cohort studies, birth cohort studies in this city. So this is the place I'm talking about. The city of Pelotas is located in the extreme south of Brazil, close to the border of Uruguay, a relatively impoverished area in a relatively wealthy area in south of Brazil. From a dental perspective, it's important to mention that water fluoridation was implemented early in the last 1960, last century. Well, in 1982, the first birth cohort study started with more than 6,000 kids who were born in the city. It's not a sample, the whole population, and then they were subsequently followed until today. We had 3 oral health assessments at ages of 15, 24, and 31 years. 11 years later, a new cohort, birth cohort study started, and this time almost 5,000 kids were followed, investigated. It's again an ongoing cohort studies, and again we have 3 oral health follow-ups. At the age 6 years, this is my PhD study in 1998, I started it. So for those who are interested in methodological aspects, you can see here all these papers, the description of the cohorts published in this cohort profile section of the International Journal of Epidemiology. Again, 11 years later, the 3rd cohort study started in 2004, and now we have to date 2 oral health sub-studies. And finally, again, 11 years later, a new cohort study started, this time using a different strategy by recruiting pregnant women, and those women were interviewed and dentally examined as well. And later on, the kids were investigated in terms of oral health at the age of 2 years. So over these cohorts, of course, we had many different factors investigated, biological samples, sophisticated exams like body packs, DEXA, and also a dental examination, as you can see here, DNA extraction, and so on. It's a very comprehensive studies looking from social to biological aspects of a person's life. More specifically to our talk today, over the years, they have collected many different socioeconomic indicators as well as the cohorts aging, and how the team improved their data collection as well. But basically, they collected income, education. They tried to create a kind of Marxist version or neo-Marxist version of social class to be applied in epidemiological studies, unfortunately with a few small practical results. But anyway, the wealth has been collected. A different strategy to stratify the population has been published as well. So it's a very rich data set to test those hypotheses that I mentioned before. So, of course, in terms of clinical data, we have several different assessments, collecting what is usual, and also improving the data collection according to the new case definitions and new disease classifications in dental caries, gingival bleeding, periodontal health, mucosal lesions, dental trauma, and so on. In addition to that, we have also some specific oral health related models, including oral health education, oral health quality of life, sugar consumption, dental fear, dental pain, and etc. So in combination with the original data, we can test some hypotheses about the influence of socioeconomic inequalities over the life course. So how does socioeconomic in oral health inequalities come about? Well, again, this is a invitation for those people involved in cohort studies over the world. I think that we need to move towards a more collaborative approach, perhaps a consortium of existing cohort studies. This is a idea under debate. So we believe that this kind of studies and a combined efforts from many different researchers from different parts of the world can answer more properly some unanswered questions that we have, including in social oral epidemiology. So, but basically here, this is the first paper of this series published more than 10 years ago, 2007, many times ago. A relatively simple paper. We collected income at birth and then household income at birth and also at participant age, this time at 15 years of age, of course, the family income or household income. And then you can see here that dental care is according to 4 different groups. Those who are considered always poor, of course, this is a relative measure. The income was divided into tertiles, and those first, second and third tertile was combined, and we call them as no poor, while those at the first tertile we call it as poor. And then this is the combination. There is a rationale, a theoretical base behind this. This is not the case to explain now, but I'm keen to to talk more about that later on. But basically, we formed 4 groups. As you can see here, there is a clear picture. First of all, the experience of dental care expressed by the MFT index was more or less equal among the 4 different groups. But what differed was the management of the disease that is suggested by the decade or missing component, and also the carry index. Basically, 3 different patterns: always poor, with the worst conditions, those who experience change or some mobility over this relatively short life between birth to aged 15, had an intermediate pattern, and those who never experienced relative poverty presented had the best indicators. And this can be explained here by the different patterns of behavior and also use of dental care in boys and in girls. Some minor difference according to gender, but this is the pattern. That's very simple, but this is the first paper of the series. Later on, in the same cohort study, 1982 cohort study, we identified the third at the 31st years of age. Now we had 3 different data collections in terms of income, and then we tested 2 different hypotheses. The first one is the cumulative risk. So the number of relative episodes of poverty over the life course expressed as none, 1, 2, or 3. And the second one, if poverty in the life course may affect unsound teeth later on, which means 31 years after birth. So, and this is the summary findings. The first one, the critical period was tested, which means experience poverty at birth. Those people had 30% more unsound dental tree in adulthood than those who didn't experience poverty in the early life or at birth. And after that, you can see a kind of dose response relationship between episodes of poverty and unsound teeth. So this is a series of 2 papers in 1982 cohort study. After that, some years ago, 3 years ago, some colleagues identify a different aspects. It's very well known that the quality of restoration is highly associated with tooth level factors, and also materials or surface or anatomical location, so on. But this time we tested if the family trajectory here identified in three different groups may affect the quality of restoration. And you can see here in the adjusted and unadjusted models that those people experience lower income trajectory over the life course, had a higher experience of unfavorable, if you like, quality of restoration. So this was the first time that some external to dental material science or anatomic or restorative science has been proposed as explanation for the fail of restorations. So in addition to very well known tooth level factors, we have also a socioeconomic trajectory as a determinant of the quality of restoration. And here's the same in a different cohort study, but now this time from childhood to young adulthood, more specifically from the age of 6 to 18, you can see again different patterns, different socioeconomic trajectories, and then the DMFT and its components from 6 to age 5. Again, basically 3 different patterns. An intermediate group, those with mobile trajectories in between those with lower socioeconomic trajectories and those in high stable socioeconomic trajectories. Moving on to periodontitis. This is quite a different, is a different explanation. Periodontitis is a more a disease that affects individuals and on adulthood and later on. But this time it tests if socioeconomic position or socioeconomic trajectories over the life course may influence periodontitis at adulthood, again at age of 31. And you can see here that this is true for severe periodontitis, not for moderate periodontitis, or what suggests there is something that happened over the life course that affects periodontal disease that's not confounded by, as you can see here, another socioeconomic variables, and also some potential mediators as smoking, dental flossing, or pattern of dental hygiene. So this is a relatively traditional approach, but more recently we used a more sophisticated analysis to respond the following research question: if there is a controlled direct effect of early life socioeconomic position on periodontitis in this birth cohort study, this 1982 birth cohort studies. Again, the main exposure here is family socioeconomic position at birth. Sex was treated as a baseline confounder. Dental calculus and smoking status were taken as mediators. Dental calculus here was a proxy of dental hygiene, and adult income and participants' education level was the time-varying confounders, and periodontal disease in different case definitions were our outcome. As you can see in this slide here, the family income, the lower socioeconomic position at birth was this time we didn't call association, we used a causal language, cause moderate to severe periodontitis in adulthood. So this is by using some techniques that can infer causality, as I mentioned earlier. And more recently also, this is another outcome, tooth loss. So the question here is if income at birth and affect tooth loss in adulthood. Again, the same birth cohort study. And then you can see here, those people poor in early life had a higher chance of having their tooth or teeth loss and in adulthood. And also the number of these is dramatically different. So this is after controlling for some very well known confounders, as you can see this in this DAG here. Well, and finally, sorry, this is a paper in Portuguese, but we tested again the accumulation of risk model, the accumulation of risk model over the life course, dividing the group into 3 different groups. The group 1, those always relatively rich. The group 2, those who experience poverty in 1 or 2 time points, and the group 3, those who experience poverty in 3 or 4 points in time of their life course. So there is a strong dose effect relationship, as you can see in this table here. So more recent, I think that last month, our colleague Roger and some Stefan, some colleagues from Sweden and we performed a systematic review, a meta-analysis of existing cohort studies, which look at these research questions: the effect of social mobility on tooth loss. The figure 1 here, you can see the comparison between the odds, the meta-analysis of the odds ratio of having tooth loss, comparing upward mobile trajectory versus persistent high socioeconomic status, odds ratio of 173, and the table 3, a comparison between those, the reference group, the persistent high income trajectory against the downwardly mobile group. And this time you can see a risk odds ratio of 2.52. And finally, as expected, the highest odds ratio, 3.96, for those people who were persistent low over the life course. So a clear picture that the systematic reviews showed, a picture that we have already showed many years ago, but apparently the phenomenon persists, which means those persistent high socioeconomic positions are the better off. Those, of course, in persistent low socioeconomic position had the worst dental outcomes. And in between, we have those experience mobility, either upward or downward mobility. What's not clear is that those people presented or had upward mobility are better or worse than those with downward mobility. This is not clear, and there is a huge heterogeneity in those 18 different cohort studies. So as a next steps, again, I think that we need multidisciplinary and multi-theme teams. So we need to have on board economists, sociologists, political scientists, and of course, clinicians, epidemiologists, and our team. If you're talking about causal thing, we need to talk about causal analysis. We are fortunate to have a new developments advance in terms of data analysis, epidemiological tools, and statistical tools as well, to deal with the differentiation between causal and causality and association. Well, we are here with ICOHIRP and GOHIRN. I think that's international collaboration is more than a desire, is a necessity. And this kind of studies is a platform, is a cohort of researchers. So we need to form and train the new generations to identify the gaps in the research that we need to answer. So, and there is much more to be done. Of course, what I showed is a very small slice of what needs to be done. We need to prepare studies taking into account the interaction between income, education, occupation, gender, race in a more complex and holistic way. So that's that was my talk. I'm very keen to talk to respond if I can some questions that you may have. I'd like to acknowledge my colleagues from the Center of Epidemiological Research from Federal University of Pelotas and the postgraduate program in Dents for the same university. Thank you very much. Thank you.
That's wonderful, Marco. I'll take over again just from the moderation point of view. And first of all, thank you for, as expected, a very academic and evidence-based talk on this topic and using those beautiful birth cohorts. Just before I actually move on, I want to make sure that I announce, in case people have to leave, that our next joint webinar between ICOHIRP and GOHIRN will be on Thursday, 14th of October at 3 p.m. Geneva time. And it's, I mentioned Geneva because it's Benoit Varenne, the director of WHO Oral Health, is coming to speak to us. So we're very pleased to announce that he will be our next speaker. But now we've got another 10 minutes or so for discussion and evaluation and analysis and questions and answers. So if anyone wants to either through the chat or come as a verbal present questioning, please raise your hand or make yourself known so that we can bring you in.
Yeah, Peter, I think we have a first question on the chat. So if you want, I can read it aloud. If you want.
Yes, please.
So it says, excellent talk. Are there studies investigating systemic diseases and oral health?
Thank you for the question. Who had this question, Carol?
Yeah.
Can I name?
Well,
Yes.
we don't know the
From-
name, but I know someone
From 001.
Tunisia. Yeah.
Oh, okay. Thank
He or
you,
she is
my
based
colleague.
in Tunisia. We don't know.
Okay.
Who it
Thank you
is,
so
but-
much. Yes, we have a couple of papers, studies publishing on the relationship between oral health and general health, more specifically about the sometimes oral health as the outcome, sometimes oral health as the exposure, but all I can say theoretically based, some plausible association, for example, obesity and overweight on periodontitis, and depression on mental health on periodontitis as well. Yes, we have some studies like that, but my talk today was focus on socioeconomic conditions over the life course on oral health. Thank you.
Yeah, that question was actually from Latifa Barazuga, who is a regular on these calls. And of course, it's a very important question in the light of the fact that at the World Health Assembly last May, we are now charged in oral health with making sure that we align our efforts to those in holistic health and general health. So are there any other questions for Marco? Marco, I'll just
Doris.
Yeah,
okay.
Doris has.
Oh, yes.
Hand up. Yeah.
Put her
Please.
hands up.
Yes.
Hi, hello. Hello, everyone.
Hi.
Thank you, Dr. Perez, for a very interesting talk. I wanted to ask if in these cohorts, because most of the things you showed were using income as socioeconomic Asher, I was wondering if there were other indicators and if you've seen the same sort of gradients or the same results using different SEP indicators.
Yeah, thank you, Doris. Very, very important questions. As I said, look, from a life course perspective, particularly after young adulthood, education is relatively a stable indicator. So in terms of education, very, very small mobility over the life course. So, but in which extent education interacts with income, for example, is a different thing that should be explored. But we, in addition to income, we tried, as I mentioned, in early 80s to operationalize a kind of social class classification, but extremely difficult to, in terms of pragmatical approach, in terms to transform this complex construct into variables, as epidemiologists would like to work. It was unsuccessful experiment, if I have to say. But we have some new developments in terms of access, more related to wealth, as I mentioned, the differentiation between wealth and income. But this is an area for develop, and now that they hosting a WHO Center for Health Inequality, I think that's one of the areas to develop of methodologies and tools to be more comprehensive in terms of data collection. Thank you.
Okay, thanks, Marco. And in fact, we have another question that's this time from George Sakos. And George, do you want to ask that, or do you want me to read it out?
Either way, I can pose it. All I said is that it was really, really good and very comprehensive. Thank you. And I would like you to comment a little bit more, if you have the time, on, you use the review of the social mobility in tooth loss, and the evidence there is quite conclusive. So I'm trying to push you a little bit further and tell me, what does this mean public health wise? What does the group take forward in terms of action, and how does it link with the determinants agenda?
Yeah, thank you very much, George. Very, very important question that we discussed this, the authors of this paper discussed the message, the take-home message of this paper. The first is the huge heterogeneity in those 18 cohorts, which suggests that contextual aspects may play a role. And so this is important. So the phenomenon is relatively, I can say, similar, but the context in which people live may play an important role. Another issue is that, as I mentioned, apparently the most distal or close to adulthood socioeconomic factors for tooth loss are more important than those in early life, what apparently contradict with some of these finds that I showed. As I said, we can have different, a combination of different theories to explain, but definitely in terms of childhood, I think that we need to reinforce the message that the first 1,000 days of life is crucial for personal development and well-being, including oral health. I think that this message is very powerful. Thank you.
Very good. And Mario Viana Vittore has sent a message as well in the chat. I'll actually read this one out. It says, many thanks for the excellent presentation. Since broader determinants of health, such as Human Development Index and income inequality, are dynamic, any thoughts on whether the changes in such distal social determinants of health would impact in oral health?
Thank you, Mario. Thank you very much. Very good question. Because another perspective that we need to add, and perhaps Carol is works in that arena, is how to add the ecological component of that, or the social structure on life course. Because you mentioned the Human Development Index. Human Development Index per se is not an individual indicator, is a community indicator. We cannot have this at individual level. So how to combine changes in the context, ecological level and individual level is a different task. To be honest, I never seen such complex studies in not in dental field, in overall health, to be honest, but this is a issue to be discussed.
Yeah, and in fact, your appeal at the end was for this multidisciplinary approach with economists and sociologists and even, you know, the political players. So you're absolutely right. This is a complex problem. Do I see any other hands at the moment? There was one that struck me, Marco. I'm just going to ask it quickly. Is the in the Paletos birth cohort, the different trajectory for caries and periodontal disease and tooth loss? And of course, we know there's different risk factors, but are there other factors at play as well?
Yeah, this is a very important question. For example, one study that we behavior is commonly used as an explanation for as the mediator linking social factors and health. But in some analysis that we performed, we found a direct effect from socioeconomic status without any mediation. So there is a material, this is another theory, of course, not a behaviorism. I know that this is very controversial, but our empirical data showed that there is a direct effect of economic disadvantage that's not mediated by behavior or even dental care. What's that? To be honest, we need to explore. I don't know. But the fact that if you thought one of these papers I didn't mention, there is a e-value there. This is a technical issue, but this is a probability of having unmeasured confounder. So to nullify the effect, and some of these direct effects, the e-value is so high, so it's very unlikely that any unmeasured confounder could confound this association. So this is it's causal association. But what's the explanation for this material or new material link? Perhaps in the coming seminars that we are proposing some scholars to present. I mentioned one of them in our paper, Carlos Montaner. He proposed a new Marxist view of this. Is a very controversial. This is sometimes a bad word to be used, but I think that's a very radical to be to the root of the problems that it's a macro structure of the society and how to explain complex phenomena. Unfortunately, needs a complex approach.
Excellent. I think, Marco, because it's just over the hour and people may have other commitments, I'd just like to thank you, and this has got this new initiative and partnership off to a fantastic start, and we really look forward to the future webinars in this space. And of course, just as I've said, the next date for your diary will be 14th October, and that's at 3 p.m. Geneva time for Benoit Varenne. Thanks, Carol, for setting this up. Thanks all the participants for your tremendous contribution to this and the discussion. And thanks again, Marco.
Thank you, Peter. Thank you, everybody. Thank you very much. Thank
Thank
you.
you, everyone. There were a couple of questions in the chat, so maybe by email we can answer directly to
Thank you.
those.
Please,
So,
if
yeah.
you like, please get in touch. I'm more than happy to talk. Okay.
Thank you, everyone.
Thanks,
Great
Carol.
session. Thank you, Marco, Peter. See
Thanks.
you all next time.
Thanks, John. Bye.
Bye.